Hi, everyone. Welcome, and thank you for joining us for the first session in our spring webinar series. And today it is on the EEG. We're pleased to have Dr. Erica Schyer as our presenter today. She is a neurologist with an additional 2-year fellowship training in epilepsy and the EEG. She joined the Epilepsy Center at Hartford Hospital, which is now part of the Hartford Healthcare Ayer Neuroscience Institute. She works as an epilepsy specialist and has also been the director of the neurology residency program at UConn and Hartford Hospital since 2009. So we welcome her and thank her for being here with us today. And just to let all the participants know, you are all in listen-only mode during this webinar. So that means if you have questions, please type them in the questions section on your webinar pad, and the questions will be answered at the end by Dr. Schyer. So I'm going to hand this over to Dr. Schyer now. Thank you.
All right, well, thank you for having me. I'm happy to discuss the EEG today. It's something that I spend a lot of time looking at, and I enjoy teaching it as well. So hopefully today we can go through some basics as well as look at some EEGs and learn about them a little bit. So what I'm going to cover today, let me see if I can get my slide. There we go. I'm going to discuss basics of EEG today. The 4 sections I'm going to cover are: what is an EEG? What information does it provide? How does an EEG help in the diagnosis and the treatment of epilepsy? And what should I expect if I am getting an EEG test done? So I'll try to go through each of those sections, and I can answer some questions if you have any at the end of the talk. So the first section I'm going to talk about is just to talk about basics of what is an EEG. So EEG stands for electroencephalogram. The EEG that I'm discussing today involves recordings from the scalp. There are some other types of EEG which can record from the surface of the brain underneath the skull, and I'm not going to discuss that in today's presentation. I'm going to limit the discussion to EEG that records from the scalp. So an EEG refers to the recording of the brain's spontaneous electrical activity over a period of time. And that is as recorded from multiple electrodes that are placed on the scalp. So you can see from this photograph on the slide that this young woman has several electrodes that are basically taped onto her head, onto her scalp, connected to wires, and that connects to something called the head box. I'm going to talk about that a little bit more. So first, some history. So EEGs have been used to look at human brain electrical activity since 1924, and that's when German psychiatrist Hans Berger recorded the first human EEG. He published his findings initially in 1929. That's a picture there of Dr. Berger, and on the right are some pictures of some of the first EEG recordings. So what is an EEG recording actually? So you hear that an EEG is recording the brain activity. So what does that actually mean? So the EEG signal that we're looking at is actually the brain waves that we're seeing, and we'll go through that a little bit too, are basically generated from thousands of brain cells or neurons that are firing in a synchronized manner. So when we see the brain waves on the EEG, that's actually the result of thousands of neurons, basically cortical pyramidal neuron cells, which are cells on the surface of the brain, which are firing synchronously. And that's what results in the electrical activity that we're seeing and picking up on the surface of the scalp. So during an EEG test, the electrodes, which are small metal discs attached to thin wires, are placed onto the scalp. The electrodes detect tiny electrical changes that result from activity of your brain cells, which is basically what I talked about, the thousands of synchronized cortical neurons that are firing. The electrodes, so they're attached to wires, and that they plug into something called a head box, and the charges that are recorded, the electrical activity that's recorded, are amplified from the head box, and they go to the computer. And then the computer just produces a display. So it basically appears like a graph on the computer. Back in the old days, before the days that computers were used for this was actually a pen and paper. So the electrical charges would cause deflection of a pen on paper, and that would result in basically an EEG recording. As a paper was running past, the pen would deflect from the charges, and it would print on a paper. These days, though, we have an amplifier, and everything is digital, so it shows up on the computer screen. These are some pictures. In most cases, the EEG electrodes are pasted or taped onto the scalp. There are some places that use a cap, and you can see this is a picture I just found online of an example of a cap that has electrodes already attached to it. And then this is an example of a head box over here, and then a computer monitor where the EEG would be displayed. So next thing I'm going to talk about is the electrode placement. So when you have an EEG, there's a standardized way of measuring and placing the electrodes to do the recording. So what we usually use in the EEG labs is something called the 1020 International System. And this is an example of how that is done. So basically, when the EEG technologist is going to place the electrodes, the initial thing that they do is make measurements on the scalp. And they have specific landmarks, for example, on the spot between, basically the nasal bridge. There's a point in the back of the skull, and then the points right in front of the earlobe, that little preauricular point that they measure from. And then they make calculations so that electrodes are basically, they're separated by either 20% or 10%, and placed accordingly. So as you can see, there's sort of a code that is used when the electrodes are placed, and you'll see when I start showing some pictures of the actual EEG recordings, how they're labeled corresponds to these electrode labels. So the way it's labeled, so F stands for frontal, so FP, it's hard to see them, I have a better picture coming up, but FP1 and FP2. So FP means frontopolar, so that's the frontopolar part of the brain. F means frontal, T means temporal, C is central, P is parietal, O is occipital. These are referring to different regions of the surface of the brain. The other way that we label the electrodes are with numbers. So there's a letter that corresponds to, basically the region of the brain that the electrode is placed on the scalp overlying that region. And then there are some numbers or small letters associated with each one. So by convention, odd numbers correspond to the left hemisphere, and even numbers correspond to the right hemisphere. And then a little Z subscript corresponds to the midline. So we have, going down the midline, we have FZ, so that's frontal midline, CZ, which is central midline, PZ, parietal midline. So those are three of the electrodes going down basically over the center. Then you have over here, over the right hemisphere, everything is labeled with an even number. And on the left hemisphere, everything is labeled with an odd number. So that's basically how the electrodes are placed and how they are labeled. Here's another picture, and this will kind of show you how the electrode placement is done as well, and how that corresponds to what we see when we look on the computer monitor. So again, we have the labels where we have the midline here, FZ, CZ, PZ, and then we have these electrodes that are labeled in blue, which are over the right hemisphere, and then A is ear, and then the electrodes that are over the left hemisphere, which are associated with odd numbers. So as you can see, we have an EEG display here, and I don't expect you from this talk to learn how to read EEGs. I'm more just going to go through some basic concepts. So when a neurologist is interpreting the EEG, we can pull up the, basically different combinations of electrodes. What I pulled up here is sort of a standard way we look at them. And you can see that the letters and number combinations correspond to different electrodes over here. Basically, and I'm just going to go to this slide next. So what some terminology associated with the EEG. So a channel is one line of EEG recording. A derivation is a description of the electrodes. Basically, for example, comparing the input in two, which is the standard way we look at it. And a montage is a collection of derivations. So this is basically the collection of derivations is called a montage. And each one of these lines is a derivation. And you can see from looking at them that you can see some patterns here. So this is what we call an anterior to posterior bipolar montage. You don't need to understand that in detail, but basically what that means is we're looking at the left side up here, the right side down here, and the midline here. And we're kind of looking at these electrode arrays where it's going from anterior to posterior. So in looking at this display, this section of electrodes here are the ones overlying the left hemisphere. These are overlying the right hemisphere, and these that have the Z are the midline. So that's sort of a typical way that an EEGer may review an EEG. You can also see here that there is also a line that shows the heart rate. So it says EKG, and so we see the heart rate down here. So this is just an example, and I'll show you some more pictures of EEGs, and we can look at some findings. So I went through some of the basic EEG terminology just so you understand some of the labels. And I'll explain here too. So typically the way we look at the screen, you can see this almost looks like a graph. The way time is measured, usually each of these solid bars, so you can see here, 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 these are 1 second intervals. So as somebody's having an EEG recording, if we were to be watching it as it was recording, you could actually see the EEG as it was recording second by second. We don't usually review it that way. We usually wait until the recording is finished and we're reviewing it at a later time and we can scroll through it. But if we were watching it live as it was recording, you would kind of see each second as the EEG was recording. You could kind of see the EEG pass on the screen as it was recording. Okay, so what information can an EEG provide? I'm going to talk about mainly EEG as it relates to seizures and epilepsy, but there are quite a few pieces of information that we can get from an EEG, not always relating to seizures and epilepsy. So that's not the only indication for getting an EEG, is to look for seizures. There are other things that we can see from reviewing an EEG. For example, probably the primary thing is that we are looking for seizures and findings that are associated with seizures, but some of the other things that we can see from looking at an EEG can include, for example, lesions in the brain can show up as slowing on the EEG. So, for example, if somebody has a tumor or stroke, you can have unusually slow brain waves in a particular region where that structural lesion is located. We also use the EEG in evaluation of critically ill patients, oftentimes with conditions that are affecting the brain. We can use the EEG to kind of make an assessment of overall brain electrical activity. And that's information that's helpful in addition to information that we gain from doing neurologic exam at the bedside, as well as looking at brain imaging, such as CAT scan or MRI. So we can look at patients, we can record EEG in patients that have conditions such as brain trauma, coma, or even brain death. Determination of brain death can use an EEG to help make that determination. Some of the other conditions we can use EEG are to collect information about brain activity and neurological disorders such as dementias. And the EEG is also used in sleep studies to determine the sleep stage and in order to help diagnose sleep disorders such as narcolepsy. So EEG is not just used for diagnosis of epilepsy. There are quite a few other conditions that the EEG is useful in. Okay, so in this next section, I'm just going to give you a little flavor of what some EEGs look like and some of the findings. A normal EEG is basically defined as the absence of abnormal patterns. So there's a big range of what can be considered normal. And some findings can be considered normal or abnormal depending on how old the patient is and what the behavioral state they're in, such as awake or asleep. There may be some findings that are normal if somebody is drowsy, but not normal if somebody's awake. Also, for example, there can be some findings that are normal in, for example, a newborn baby, and if you looked at the EEG, but would be very abnormal if you saw that finding in an adult. So you really have to know the age of the patient as well as the behavioral state in which you're doing the recording. So in reading an EEG, some of the first information that we need to find out before we review it are, what is the patient's age and what is the behavioral state when they're having the recording done. And as I said, some findings that are normal from one age or state may be abnormal in another. So when I'm reading an EEG, there are a few things that we look at first. So in general, the first thing we look at is the general, what we call background activity. So that's just a general pattern of frequencies, how the EEG is organized. Are the hemispheres symmetric? So is are you seeing the same thing over the right hemisphere as over the left hemisphere? And how does the EEG react when the patient is stimulated? So those are things we look at on every EEG that we're when we're reviewing the study, we're looking at general patterns and the general organization and the composition of different frequencies that, that compose the brain activity. So that's something we look at. And then on top of that, we're looking for findings that are transient. So there's an overall background as you're reviewing the EEG, and then you're looking for findings that are intermittent that may be either associated with seizures or associated with other abnormalities that are important to detect when you're reading the EEG. So I'm just going to go through a few pictures and give you some examples of some EEGs that, some common patterns that we see, and some of the things that we're looking for when we are making a diagnosis of epilepsy or trying to figure out what type of epilepsy someone may have. So this first example of an EEG that I'm showing you here is just an example of an adult who is awake, and it's a normal awake background. So just to show you, and I don't expect you to be able to read one of these, but just to have an idea of, when I'm looking at an EEG, what kinds of things I'm looking for. So as I mentioned before, these are the electrodes. This is, again, the left hemisphere, these electrodes up here. The right hemisphere are these even-numbered ones, and the midline ones are the ones that are labeled with the Z subscript. And then you also see the heart rate down here. The solid lines indicate 1 second. So basically, if you could calculate the heart rate, if you have 10 seconds and then you count the number of heartbeats and you multiply that times 6, you can get the resting heart rate from looking at this. And you can also see the frequency basically per second. For example, if you can count how many, basically these waves here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you see that a lot of this EEG has this 10 hertz pattern, which is a normal pattern to see if somebody is awake. Okay, so as you can see, this is awake, this is asleep. They look very different. So when somebody's awake, you see mostly faster frequencies, usually in the 9 to 13 hertz range. When somebody is asleep, you see a much different background pattern. So here is an example of when an adult is sleeping, you see a lot of slower waves, and then you see a lot of these really fast waves that are in certain channels but not in others, and then you see these big sharp things here that look like V's. These are all normal patterns in what we call stage 2 sleep. So there are some features of sleep that we see here. For example, these are called vertex waves. This is a normal pattern that we see when somebody is asleep. However, if we saw something that looked like this when somebody was awake, it would look very abnormal. And then these fast frequencies, you see right here, usually 14 to 16 per second, these frequencies here. These are called sleep spindles. So this is a feature we see when somebody is in, there are different stages of sleep that get deeper, and then you have REM sleep. This is one of the characteristic features that you see if somebody is in stage 2 sleep. Okay, so this is just to show you an example of how an EEG just in the same person could look very different depending on if they're awake or if they're asleep. So this is an example. So if somebody were awake, and this is what their EEG looked like, you can tell compared to this one here that the frequencies, so the waves here are a lot slower than the ones that you saw in the first one. So in this one, a lot of the frequencies are more like 2 per second, and then there's some here sort of mixed in that are more like, 6 per second, 7 per second. So, so this is an example of an EEG background that just looks a lot, looks too slow. This is an example of an EEG that looks too slow over one hemisphere. It looks a little slower in the front on the left too. So, but if you look at this EEG recording, you can see that there's a difference between what you see on the top half of the screen compared to what you see on the bottom half of the screen. You can see there are these very slow waves, a little bit less than, could be about 1.5 to 2 per second, that you're really just seeing over the right hemisphere, so these even-numbered electrodes. Whereas on the left, you really don't see those slower frequencies. So that means that there's probably some sort of structural lesion in the right hemisphere. And in this one, it looks like it's really over the whole hemisphere, but a little bit more prominent over the frontal electrodes and the central electrodes. So this could be, for example, in somebody who's had a stroke or a brain tumor involving the right hemisphere more in the frontal part. So that's an example of slowing over one hemisphere. Now this is an example of something we call focal slowing. So this is also something that an abnormal finding, and I'll point it out here. This up here you see, it looks like you see nice faster frequencies like what we saw in that first slide where we had the example of somebody who's awake. But if you look down here, you see some of these slow waves down here. And the electrodes that you're really seeing them in are the sort of the right temporal electrodes. So this is something that we call focal slowing. Focal slowing can also indicate a structural lesion, or it could also indicate that that region of the brain functionally is just not working properly. So it's sort of a nonspecific finding, but it is abnormal, and it indicates that these unusually slow waves that you see over the right temporal region, but not over other regions, may indicate that there's something not right in the right temporal lobe. So, so that's an example of focal slowing. So we saw an example of generalized slowing, where everything's too slow. We saw an example of hemispheric slowing, where half of the brain looked too slow. And here we're seeing an example of focal slowing, where one region of the brain looks too slow. So these are some of the things that when I'm reading EEGs, these are some of the things that I might notice. Now, so far I've not talked about EEG findings in epilepsy. And so that's what I'll talk about next. So some terminology that we use in terms of EEG for epilepsy. Ictal EEG is the EEG, that's what the EEG looks like during a seizure. So that's called Ictal EEG. And then interictal EEG is the EEG when someone's not having a seizure. And so that's important to differentiate. We want to know what, most of the time, if somebody with epilepsy is having an EEG recorded, most of the time, hopefully, they're not having a seizure. And you would record a seizure, more times than not if you're doing a recording in the hospital or a longer-term recording. It's not as common to record seizures in a typical outpatient recording, and I'll get to that in a later section. So, okay, so when we're reading EEGs in regards to looking for findings associated with seizures or epilepsy, we're looking for something called epileptiform abnormalities. And that term means an epileptiform abnormality is a finding that's associated with seizures. So it doesn't mean that it's a seizure itself. It means that it's a finding that if we see it, that indicates an increased risk of seizures. So it indicates irritability of the brain. Now, interictal findings or epileptiform abnormalities that are associated with an increased risk of seizures, usually they're sharp or spiky in appearance. And their location can help indicate what part of the brain is irritable. So for example, with focal epilepsies, we can see oftentimes when somebody's not having a seizure or during the interictal EEG, we may see some focal epileptiform discharges, meaning we see something sharp or spiky that occurs intermittently in the region that is irritable. Now, with generalized epilepsies, oftentimes the interictal epileptiform abnormalities are seen diffusely, so they're seen across all of the channels. So I'm going to show you now a few examples of that. So first I'm going to show you a couple examples of focal discharges, and this one's a little subtle. So this is an example of a sharp wave. So this is an example of an epileptiform discharge that is located focally in the right temporal region. So you kind of see it at temporal electrodes, and it's sharp. So it looks like, almost like a tack or something that would be, basically looks sharp. Then here we have is similar to this one here, but on this next page, we actually have a train of them. So they're seen a little bit more frequently. So we see this little train of sharp waves in the right temporal region. So these findings here, single as well as a train of sharp waves seen in the right temporal region, these are indicating that the right temporal region is probably irritable and prone to having focal seizures. So we're not seeing a seizure on either of these slides, but we are seeing a finding that would indicate that there's an increased risk of focal seizures that would likely, if somebody were to have a seizure, that they would come from the right temporal region. Now, these discharges don't tend to cause symptoms. So if somebody has this intermittently on their EEG, they're not going to necessarily experience any symptom when this is happening. It is possible, for example, if somebody's having very, very frequent discharges, sometimes it is felt that that could affect the thinking or the cognition. But with this type of discharge, especially if we're seeing it just during sleep or we're seeing it just here and there, is not going to be causing any type of symptom. Here's another example of a more focal-looking discharge. And this one you can see a little bit more in both temporal regions. So you see it a little bit more on the right side, but you can see it on the left as well. So these are examples of focal discharges. This is also another example of focal discharges that are associated with a type of epilepsy called benign Rolandic epilepsy. That's a type of epilepsy that's often seen in childhood, and it has very sort of characteristic-looking sharp waves that basically runs of spikes, which is the term for these sharp discharges that are located in the centrotemporal region. So you can see these trains of spikes mostly during sleep. Now I have a few examples of generalized discharges. So we talked about with the focal epileptiform discharges, those indicate a region of irritability in the location where we are seeing the discharges. With generalized discharges, these are the types of discharges that indicate these are associated with generalized epilepsies, and you see them really diffusely. So oftentimes with the generalized discharge, you may see basically a train of spike and wave discharges, they're called. So this is a spike and then a wave. So you see a spike and a wave, and each one of these has a spike and then a wave, and you can count, we basically describe the discharge in terms of how many per second we see. So this is an example of a 3 Hertz generalized spike and wave pattern, which is often seen in association with absence seizures. This is an example of a generalized discharge, and you really see it across all the electrodes at the same time, starting at the same time, and they look very sort of monomorphic. You can usually see them, usually the wave component, the spike and wave component, you see a little bit higher amplitude in the frontal electrodes, but it really is a diffuse discharge. You see it really all across as compared to some of the focal discharges where you really just see them sort of in a specific region. These you're seeing all across all of the derivations. This is another example of a generalized discharge. It's a little bit less monomorphic, so you kind of see these spikes intermixed, but you kind of see them across all the different derivations. Okay, so those are some examples of interictal epileptiform abnormalities, meaning discharges that are not seizures that indicate an increased risk of seizures. Now, Ictal EEG, as I mentioned, Ictal EEG means EEG that is done during a seizure. Now, if you are getting a routine EEG, meaning you're coming into the EEG lab and having a recording that lasts, between 20 minutes and an hour, let's say, typically you're not going to record a seizure in that time frame. In order to get Ictal EEG, typically that's when we're bringing somebody into the hospital for video EEG monitoring for the purpose of recording seizures in the hospital in order to get an idea of what type of seizures they are and to sort of get more information about them. Now, if we're trying to get Ictal EEG, trying to record seizures, oftentimes we schedule an admission to the hospital with the plan to try to record the typical seizures that are occurring at home. And if somebody's in the hospital, we're able to do things such as lower or stop the medications. And we're also able to do some testing during the seizure to see, for example, if somebody is able to respond at all or respond in a limited manner while they're having the seizure. This can be very helpful in cases where somebody may be having some type of recurrent event, and it's hard to tell by the description alone if it is a seizure or not. Also, in people who we know have epilepsy and we're trying to determine what type of seizures they're having, recording an Ictal EEG can give us an idea of where the seizure is starting. Does it look like a focal seizure or a generalized seizure, and really to characterize it. And then for other patients who are undergoing a pre-surgical workup, so for patients that have the type of epilepsy that have not responded to multiple medication trials, and there's a suspicion that, or there's a lesion that's seen on the MRI that may indicate that the site of seizure onset could be resected surgically, it's important to record Ictal EEG, so record seizures, in order to help localize the region where the seizures are starting. So I'm just going to show a couple of slides now that are examples of seizure discharges. So this is an example of a generalized seizure. You can see it's a little bit different. There's some spaces here that weren't there in some of the other EEGs I showed you. It's just a matter of how people like to review the EEG when they're looking at it. But this is an example of a generalized discharge. Now this we know is a seizure discharge, and we know that because we can kind of see that there's some notation by the technologist that there were some symptoms during it. So with an absent seizure, oftentimes there's a behavioral arrest, meaning whatever somebody's doing, they just kind of pause. And it usually lasts for several seconds. They may have some eyelid fluttering, and they may be briefly unresponsive. So this is an example of the technologist had noticed some eye flutter, and they're also introducing a word for them to remember to see if they are able to remember a word that was introduced during this discharge. But this right here shows an example of a generalized 3 Hz spike and wave discharge, and this is the classic pattern that we see with an absent seizure. Now, this is another example of a generalized seizure. So this is somebody who has a very abnormal background, because this actually is interictal recording here. And then this is an example of a type of seizure called a tonic seizure. And with this type of seizure, what we see is a generalized, it's called an electrode decrement. So just across the board, all the electrodes, the electrical activity just sort of suddenly gets a very low amplitude. And this is the type of pattern that we typically see with something called a tonic seizure. And then this is an example of an EEG example. It's not the whole seizure, because this is only, this is probably 15 or 20 seconds. Actually, maybe a little bit more than that, just because they're divided up 1 per second this way. But this is an example of a focal seizure, where you're really seeing sort of the onset of this rhythmic, spiky discharge that you're seeing in the right temporal region. So this is an example of a focal seizure. If we kept scrolling through, and I just have one page pasted onto this slide, but you could potentially see it, what we call evolve. So it starts off in the right temporal region. Potentially, if the seizure spread, and it could spread over the hemisphere, or it could spread across the brain, resulting in a tonic-clonic seizure. But this is a seizure that's definitely focal at onset. Now, in terms of EEG, there are a lot of things to be careful about. Interpreting the EEG, I just went into some of the basics. There's a lot of subtlety to it as well. But when interpreting the EEG, one thing that you need to remember is that if there's something that looks spiky, it may not be an epileptiform discharge, and that's something that we have to be careful about. We don't want to say that somebody has findings that are highly associated with seizures if they don't. And so we have to be very careful that if we see something that's sharp or spiky on the EEG, that it's not due to an artifact, meaning something that's not from the brain in origin, or there are some benign variants and just normal variants of the EEG that we can see that are not associated with epilepsy. Now, for a lot of these artifacts, video can be very helpful in determining if something is an artifact. We typically include video when we do all of our EEG recordings. That way, if somebody has symptoms or a seizure during the recording, we can see what it looked like. And also, it's very helpful in determining if we see something on the EEG, we're not sure what it is, we can look at the video and try to tell. So this is just an example of an artifact that you can see. So this is a pretty normal looking EEG. All of a sudden, for these few seconds, you see these really slow waves, and it really just doesn't look right. Now, this is an artifact from somebody who just briefly shook their head back and forth, and this is the result on the EEG from them shaking their head for a few seconds. This is an example of what an EEG looks like if somebody's chewing. So if somebody is eating or chewing gum while they're having an EEG recorded, the muscles and movement from the tongue and the mouth end up causing this type of artifact that makes it very hard to interpret the record. And if you looked at it quickly, it almost there's some seizure patterns that almost look like this too. So it almost you have to do a double take. But this is an example of artifact from chewing. So in this last section here, I have one more section to talk about. I'm just going to talk a little bit about what to expect if you are planning to have an EEG done, or someone you know is planning to have an EEG done, just to go over some basic things of what to expect and how to prepare. There are different study lengths, so depending on what your doctor recommended, they may order what we call a routine length EEG, which is a typical EEG, and that's meant to look at an interictal sample to see what the background EEG looks like and to look for intermittent transient findings. Typically, those record between 20 and 45 minutes in length. There are also more extended EEGs, and these extended, so up to several hours in the EEG lab. That's more when you're looking for a particular symptom. So these longer EEGs are most commonly ordered with the goal of recording some type of symptom. Sometimes somebody may have a certain type of symptom that occurs pretty frequently, or they have something that can reliably cause them to have it. And so it may be long enough to record for several hours in order to record the symptom. There are also circumstances where we would either, as I mentioned before, electively admit somebody to the hospital with the goal of recording their seizures, or there are some cases where a take-home EEG can be worn for 24 to 72 hours in order to record typical symptoms. Now, the ideal study in order to record seizures is really the one that's done as an inpatient. There are several reasons for that. One is that we can lower the medications to make it more likely for somebody to have a seizure. We can't do that as an outpatient. That wouldn't be a safe thing to do. The other thing is that if somebody is in the EEG lab or in the epilepsy monitoring unit, if they're having a seizure, we can do some testing on them to see if they're responsive during it and to try to get a good recording of it. Also, if a patient is in the hospital, the electrodes can be repaired. If one comes off, somebody can fix it right away. But if you're wearing an ambulatory EEG home and one of the electrodes comes off, it won't be fixed immediately. So there are a couple of pros and cons. Sometimes an ambulatory EEG is helpful if somebody's having something in their sleep overnight, every night, and you want to try to record that. So there are different circumstances where your doctor may choose, choose which study to do. Now, for preparing for the EEG, and I took some of this information from some of our patient handouts, before the day of the EEG test, so when you see your doctor at the time when they're ordering it, make sure to discuss what medications you're taking. There are some medications that can affect the EEG. It is important to talk about and to make sure whether or not you should continue taking those medications at the time that the EEG takes place. I always tell people that if they're not sure, they shouldn't stop taking any medications that are prescribed. But you know, it is important to discuss with the doctor that ordered the EEG, as well as when you come into the EEG lab. If you have a medication list with you, then the doctor who's reading the EEG, you know, they have a updated med list, so they can see if they see a certain finding, if there's a medication that could be causing that finding. Many times people are instructed not to have caffeine for 12 hours before the test. Not everybody does that, but that's something that oftentimes is instructed. The other thing to prepare for it is that since the electrodes will be attached to your scalp, you need to make sure that your hair is clean and dry for the test. It's recommended not to put any sprays or gels or oils or creams or lotions or anything like that in your hair before you have the test done. And the hair also needs to be dry. And that makes it so that they can attach the electrodes properly. The other thing to remember is that for a longer study, it's particularly one that you're going to be wearing the EEG for 24 hours, let's say, it's important to wear a button-down shirt that will make it easy to change clothing without dislodging the electrodes. So those are some ways to prepare for the test. Now, during the EEG, the EEG technologist will attach approximately 18 electrodes to the scalp. They usually will use a small amount of non-allergic paste. They may rub the skin on the scalp for a little bit to make the skin rough and to remove the hair oils in order for the electrodes to be pasted down and really stay and record properly. And then they have the wires that attach to electrodes. They may wrap them in gauze to keep them bound. And then they may also attach as we saw that you could see the heart rate, they will also attach 2 EKG electrodes to the mid-upper chest and left rib cage. Then if it's an EEG that you're wearing outside, so for example, this is for an ambulatory EEG that you would wear home, oftentimes there's some sort of harness or sort of like a fanny pack that the EEG head box where the wires connect is stored in there. When you have an ambulatory EEG, you're also instructed to keep a written journal to track any symptoms that you may have, and the equipment has a little event button that you can press during the EEG if you have any symptoms, and that puts a mark basically on the EEG record that can be viewed later when the neurologist is reviewing the EEG. Now, if you're coming into the EEG lab to have the test done, what you should expect is that when you're having the recording done, you'll be asked to lie still with your eyes closed. The technologist will watch you directly or through a window during the test. The recording may be stopped from time to time if you need to stretch or change position. The technologist may also ask you to do some different things to see how the brain activity responds. For example, oftentimes you may be asked to do a session of hyperventilation. The other procedure that may be done is that there may be a flashing light called a strobe light that's flashed during the test. And lastly, you may be asked to go to sleep during the test. In some cases, the test is ordered to be what we call a sleep-deprived study, in which you're instructed to not necessarily stay up all night, but to basically reduce the amount of sleep the night before the test to make it more likely that you would be able to fall asleep during the study. During the ambulatory EEG, I think I mentioned most of this already. You have the wires, you take it home, you basically leave the testing facility and then return back with the EEG equipment, either at 24 or 48 or 72 hours. For studies that run longer than 24 hours, there may be additional instructions for replacing batteries in the unit that you take home with you. In some cases, some ambulatory studies, there's a video camera that you may be sent home with, and you'll also receive instructions on how to use the video component. And then the other thing, just to remind you also, if you're getting an EEG done, as I mentioned, as I showed you before, some of the artifacts that we can see is obviously you can still eat your meals, but to avoid chewing for long periods, for example, for chewing gum or having chewy snacks, because when you're chewing, it's not really possible to interpret the EEG that well. And then lastly, if you do wear a take-home EEG, it's not advised to shower. You can clean up, but you shouldn't actually get in the shower so as to not damage the equipment with all the wires and stuff. So in conclusion, the EEG is a useful, non-invasive test that can help your doctor to diagnose and to treat seizures, as well as some other things. And that the patterns that are seen on the EEG both during and in between seizures all provide helpful information about how the brain is functioning. So our goal overall, of course, is no seizures, and I will conclude the talk there and see if we have any questions. Okay, I can see I have one question over here. I'm trying to see if I'm only able to see a little bit of it at once. So I'm just trying to scroll through it. So I have one question, and I'll try to summarize it. So this is referring to, it says, this person is talking about a primary generalized epilepsy that was diagnosed with an inpatient video EEG and recorded after decreasing the medication. Is there a condition under which it would be necessary or recommended to repeat the test in the future? And is this a definitive diagnosis that will not change in the future? So in terms of primary generalized epilepsies, many of them do have onset in childhood, and there are some cases, there are some types of childhood generalized epilepsies where the seizures can be outgrown. So it's hard to know without knowing the specific syndrome if it's possible that it could change in the future, but there are definitely some cases where somebody may start having seizures in the childhood years and they may not continue to have epilepsy as an adult. There are other types of idiopathic generalized epilepsies with onset of seizures in childhood where it is more of sort of a lifelong syndrome and medications will be needed in the long term. Sometimes in order to try to tell once a child is getting towards getting towards the age of 18 or you're trying to tell if they may have grown out of it or not, an EEG could be repeated at that time. And sometimes, I'm not a pediatric neurologist, but in some cases, if it's suspected that it may be a type of epilepsy that does not persist in adulthood, that there could be a trial off of medication at some point, and an EEG could be repeated as part of that evaluation. So that's a good question. Now I see I have another question here. How often is an EEG recommended as an adult? First diagnosed at 21. So the answer is it's a little bit complex. So it really depends on what type of epilepsy we're talking about. A lot of times, for example, with we're just talking about idiopathic generalized epilepsies. If there's an idiopathic generalized epilepsy that has persisted in adulthood or the onset is in adulthood, oftentimes those are epilepsy syndromes which will require long-term treatment. An EEG does not necessarily have to be repeated on a regular basis. If the type of syndrome can really be determined by the initial EEG, and the seizures are well controlled with medications, there's not really an indication to do EEGs at regular time points. But if there were there may be situations where seizures start as an adult, where it may be a type that where somebody could try to come off medications at some point in the future, and an EEG sometimes is used at that time to see, for example, I showed you some interictal epileptiform discharges. So, for example, if somebody had an EEG done and it showed frequent epileptiform discharges, that probably you wouldn't want to try to lower the medications. Sometimes EEGs are also repeated, for example, if we're trying to record symptoms. So the answer is it really sort of depends on the situation, but there's not really an indication to just sort of repeat them on, repeat EEGs for everybody at a regular interval. So that's a really good question. Okay, so I think those are all the questions that I'm seeing. I'm scrolling through just to make sure I didn't miss something. Okay, so it looks like that is the last question I see there. So unless there are other questions, I guess I'll conclude the webinar. And I just wanted to thank everybody who's listening for joining us.
Thank you, Dr. Schuyler, and thank you, everyone. We hope that you're a little bit more wiser on this subject now, and we would like to just direct you to our website if you'd like to listen again or point others to it. Our website for the Epilepsy Foundation of Connecticut is epilepsyct.com, so you can go on there and listen again if you choose. So thank you, everyone, and thank you, Dr. Schuyler.
Yeah, thank you.
Bye.